How to master 100 plus anesthesia drugs without memorizing 100 plus drugs. Welcome to your CRNA Pharmacology Prep. Today we're going to tackle one of the things that can feel overwhelming when you're preparing for nurse anesthesia school. The drugs. You open a pharmacology textbook or a drug database and suddenly you're looking at what feels like hundreds of drugs. Different doses, different routes, different mechanisms, different side effects, different contraindications, and the natural reaction is, how the hell am I supposed to memorize all this? Here's the good news. You aren't supposed to memorize them as 100 or 200 completely unrelated drugs. That's the first concept I want you to understand. Instead, we're going to build a pharmacology map. And that map starts with receptors. Part 1. Part 1, don't memorize the drug. Understand the drug. Let's take phenylephrine. You could memorize phenylephrine is a vasopressor. You could memorize its dose. You could memorize that it causes hypertension. You could memorize that it can cause reflex bradycardia. But that's a lot of disconnected information. Instead, let's start with one question. What receptor does phenylephrine stimulate? Alpha-1. Good. Now ask, what does alpha-1 do? Well, it causes vascular smooth muscle contraction. So, alpha-1 causes vasoconstriction, which increases systemic vascular resistance, which then increases mean arterial pressure, MAP. Now, suddenly you understand phenylephrine. You don't have to memorize the final effect. You can derive it. And that is a skill I want you to develop. Part 2, your pharmacology equation. Part 2, your pharmacology equation. For almost every drug you learn, I want you to think drug, target, mechanism, physiology, clinical effect, dose, then side effects, and finally, patient-specific considerations. So that's your basic CRNA practice, pharmacology practice algorithm. Let's use it again. Phenylephrine. Drug, phenylephrine. Target, alpha-1 receptor. Mechanism, alpha-1 stimulation causes vascular smooth muscle contraction. Physiology, vasoconstriction. Clinical effect, increased SVR and then increased MAP. Then you attach dose. And finally, side effects and patient-specific considerations. This order matters because now the dose has a conceptual home. I'm not putting in the dose right now because I don't want you to memorize the dose. I just want you to know that the dose is there because some of the institutions will vary. So again, here's the concept. The algorithm is drug, target, mechanism, physiology, clinical effect, dose, side effects, and then patient-specific considerations. Once again, that's drug, target, mechanism, physiology, clinical effect, dose, side effects, patient-specific considerations. Drug, target, mechanism, physiology, clinical effect, dose, side effects, patient-specific considerations. Drug, target, mechanism, physiology, clinical effect, dose, side effects, patient considerations. Drug, target, mechanism, physiology, clinical effect, dose, side effects, patient-specific considerations, and finally, drug, target, mechanism, physiology, clinical effect, dose, side effects, and patient-specific considerations. That's your basic CRNA pharmacology algorithm, and we're going to be going with that. Part 3, your database. So we've already had a list of, let's say, 100 or so common anesthesiology drugs. At first glance, it might be intimidating, but when we organize these drugs by pharmacology, something interesting happens. Many of those drugs are members of the same families. You don't actually have 118 completely different things to memorize. You have a much smaller number of pharmacological concepts that generate those drugs. For example, the database contains a large number of ACE inhibitors, captopril, enalapril, lisinopril, ramipril, and several others. You don't need 8 separate mental boxes. You need to understand ACE inhibition. Now, ACE inhibition decreases angiotensin II. That decreases vasoconstriction, and it also increases bradykinin, Bradykinin? Bradykinin. And then you understand the common class effects. The individual drugs become variations on the same theme. That's the trick. Part 4, beta blockers. Your database also contains a large number of beta blockers. Atenolol, bisoprolol, esmolol, metoprolol, propranolol, labetalol, sotalol, and others. Again, don't memorize them as 8 unrelated drugs. Start with beta-1 blockade. What does beta-1 normally do? Remember, beta-1 equals 1 heart. Beta-1 stimulation increases heart rate and contractility. So beta-1 blockade tends to decrease sympathetic cardiac activity. Now you can understand why esmolol, metoprolol, and other beta-1 selective drugs can decrease heart rate. Then you learn what makes each drug unique. For example, esmolol is extremely useful in anesthesia because of its short duration and rapid titratability. So now you have a framework. Again, this is all about receptors. Then part 5, the first 5 drugs I want you to master. We're going to start actual anesthesia drug masteries with 5 vasopressors: phenylephrine, norepinephrine, epinephrine, ephedrine, and vasopressin. Once again, that's phenylephrine, norepinephrine, epinephrine, ephedrine, and vasopressin. Neo, levo, epi, ephedrine, and vaso. Why these 5? Because they teach you an enormous amount about receptors: vascular tone, cardiac output, heart rate, SVR, blood pressure, and shock physiology. Once you understand these 5, you'll have a much stronger foundation for anesthesia. Part 6, phenylephrine. Let's start again. Phenylephrine, alpha-1 antagonist, alpha-1 agonist. Think squeeze. Alpha-1 stimulation causes vasoconstriction. Vasoconstriction increases SVR. SVR increases MAP. So phenylephrine, alpha-1, vasoconstriction, increase SVR, increase MAP. Now here's your first clinical question. Imagine you're inducing anesthesia. The patient's MAP falls from 82 to 55. Heart rate is 48. What receptor could increase vascular tone? I just mentioned it. Alpha-1. What drug is a class alpha-1 agonist? That's phenylephrine. Neo. Good. But now I want you to ask a harder question. Is phenylephrine automatically the correct drug? Not necessarily. Why? Because the patient is already bradycardic. Remember, we went from something to heart rate of 48. And Neo can produce reflex bradycardia. We know that because we studied the receptor, alpha-1. So increasing afterload isn't necessarily what you want in every patient. So that's the difference between knowing a drug by the name and understanding a drug by its physiology. Next time we're going to go with part 7 and continuing on to levo and a couple of other vasopressor drugs. But this is some good things that I want you to start with. Again, the most important part is we're going to be focusing on the physiology of the drug and the algorithms of how it relates to the patient rather than just the name of the drug. We're going to go a little bit of a deeper dive rather than just knowing, oh, that drug is a vasopressor, so it increases blood pressure and eventually the MAP. No, we're going to actually try to condense a bunch of extraordinarily disconnected information and put it into a more organized way that we can use to apply to our patients in order to keep them safe. So again, let's go over with what is our algorithm. That's going to be system algorithm is going to be drug, target, mechanism, physiology, clinical effect, the dose, depending on the institution, then the side effect, and the patient's specific consideration. So drug, target, mechanism, physiology, clinical effect, the dose, side effects, patient-specific considerations, drug, target, mechanism, physiology, clinical effect, dose, side effects, patient-specific considerations. That's our CRNA pharmacology algorithm. Keep an eye out for my basic receptor overview. That's really going to be the key to the rest of this pharmacology series, because we're mostly going to focus on those receptors All the other drug basically just focuses on these group of receptors, and it's a lot easier to memorize the receptors than it is to memorize every single drug. That's just trying to assume that each drug is its own entity when it really has a lot of commonalities, and that commonality, the bottleneck, are receptors. All right, this is Nurse Howie out. Check out my other videos, and definitely look out for that general receptor video. And then we're going to keep going with quite a few lessons in order to master all this pharmacology before we start CRNA school. See ya.